This is a case of acute internal carotid artery occlusion treated with endovascular mechanical thrombectomy and extracranial stenting. This is a 56-year-old male who presents to the emergency room with acute onset of right hemiparesis for about 2 hours. NIH stroke score is 14, has prior history of hypertension. CT perfusion reveals entire left MCA with increased time to peak, with decreased but preserved volume, some hypointensity of flow and volume in the left basal ganglia. Subsequently, angiogram revealed occlusion of the cervical carotid. The left carotid is then traversed with 6 French guide catheter, and another angiogram reveals critical narrowing with a pseudo-occlusion of the left internal. The balloon guide catheter is now inflated in the left common. A 9 French system is now placed so that a 9 French balloon guide can be used. The lesion is crossed with a simple wire. Once we are in the petrous, a microcatheter is brought up and an angiogram is performed, which reveals what appears to be distal ICA proximal M1 occlusion. Thereafter, through the microcatheter, a stiff 014 wire, like a Spartacore, is brought up, and a wall stent is brought into place and initially opened using unsheathing, and then progressively, aggressively opened through the narrowing. Thereafter, while the balloon is still inflated, we use a balloon angioplasty to open the waist at the level of the severe decreased lumen or prior stenosis. An angiogram at this point reveals intracranial flow. However, there remains left M1 occlusion. AC appears to fill from this side as well as from the contralateral side. Thereafter, we advance the microcatheter and wire system. As previously noted, into the petrocavernous junction. And over that system, an 071 aspiration catheter is being advanced as well. A J-wire shape is used to remain intraluminal and advanced into and up to occlusion, and again the J-wire is used to traverse the occlusion to get distal into what looks like the superior trunk. Microcatheter is advanced into the superior trunk and a microinjection confirms location. At this point, the aspiration catheter is noted in the paraclinoid segment. A stent retriever is then delivered. This stent retriever is a Trevo, as noted by the markers. This is allowed to retain in place for a few minutes. Thereafter, aspiration is applied through balloon guide catheter. The aspiration catheter is connected to the pump, and slowly the stent retriever is retrieved. A Aggressive aspiration is applied and the stent retriever is pulled out of the head collectively along with the aspiration catheter. And one can immediately note revascularization of the superior trunk with minimal flow into the ACA, which was previously noted. Some distal branch occlusions are still noted. The cervical stent appears to be widely patent.